he sits bolt upright in bed and says, "Stop, don't cut my Carhartts." And he woke up and was fine. And we were like trying to wake him up the whole time. And he was just totally unconscious, playing possum. Apparently, he had a family member. They were in some dispute over some inheritance. And he thought the only thing he could think of, and there was a rifle pointed right at him. And he said the only thing he could think of was to fake his death and grab his chest and collapse to the ground and pretend like he had a massive heart attack. And then when he did that, I guess the relative that was pointing the gun felt guilty, and he dropped the gun, picked him up, and brought him to the hospital. So I don't know if he's just trying to scare him and he wasn't really going to shoot him. And I said, "Oh my God, you got to be kidding me." And the guy was fine. And I said, why did you think of this? He goes, "I don't know. I saw it on TV once and it seemed like a good thing to do. And it got him out of a jam." And he was really upset that we cut his Carhartts. I guess they're pretty expensive overalls. But that was so many years ago. But I just remember, like, it was just the craziest thing. Will you still need me? Will you still feed me when I'm 64?
And now the podcast where together we discuss proactive aging on your terms, connecting to the professional advice of our special guests while creating better days throughout the aging process. Now here's your host, Mark Turnbull.
Hello, everyone, and welcome back to another lively discussion on aging. Today, we are the podcast where together we explore the many options to aging on your terms. You can find Aging Today and our past 8 years of programming on our website. All you got to do is go to agingtoday.us. And I want to thank all of you for tuning in today for another lively discussion. And we're going to be talking about concussions. We're going to be talking about over the 5 million people that go to the ER every year to report some kind of a concussion. And here to lead us in this discussion is our expert for today. His name is Dr. Chris DeValantis, and he is the Senior Medical Director at Abbott and also the board-certified emergency medicine physician. So, Dr. DeValantis, welcome to Aging Today.
Thanks for having me, Mark.
Yeah, I'm very excited to have this conversation because it is a really important conversation that we should be having, and not just for the population in general, but in particular for our senior population. I'm a in-home care agency owner. We have over 60 caregivers that are in various homes throughout the Portland area, and oftentimes our seniors take a tumble, even with the care of our caregivers. And when that happens, some interesting things can happen if we don't pay attention. But before we get into our topic of the day, I'm very curious about your story and what led you to become a doctor. And then as an emergency medicine physician, I got to ask your top 2 favorite stories in the ER.
That's great.
So let's start with how you got to be a doctor. Were you, as a child, were you always interested in medicine?
I was that nerdy kid in biology that liked to dissect the worm and the frog. And I was just fascinated by anatomy and physiology and how living creatures work. And I always really loved that. And I volunteered at an early age. I think I was in 7th grade because nobody in my family was in medicine. My dad was a Greek immigrant, worked in a factory welding army tanks together. And I was the only one that pursued medicine. And I volunteered in an emergency room in the hospital where I was born in Northwest Indiana, and just to see and get exposed to it. Because back then we didn't have George Clooney and Emergency and all these like Grey's Anatomy shows. We had MASH. And we had, there was a show called Emergency back then, with Johnny Gage and Roy DeSoto. So it actually was one of my early.
I remember that one.
I remember that, Squad 51 and Dr. Becker with the sideburns. And
yep,
so
I do.
I wanted to be a firefighter, paramedic, just like Johnny Gage and Roy DeSoto. So I said, that's what I want to do. And then maybe I can be an ER doctor too. So I think it started at a young age, even back, I can think 7th grade is probably the earliest I can think. And then I worked my way through medical school by driving an ambulance. I became an EMT in college. And then I've always kind of forged this path toward emergency medicine, which always excited me because you get, for the reason you mentioned, there's always crazy stories. I could think, I've been doing this 28 years. I can tell you a lot of stories, some of them probably not rated PG, things that, foreign bodies where they don't belong and things like that. But the craziest story, I think, was right out of residency. I remember we had a hospital that was in a rural setting in Kansas, and I also worked in the city hospital as well. And I was working there one night, and some guy comes carrying in this guy in his 40s, and he was limp, and he came in saying, help me, my nephew's, or my uncle's dead. And he came, so we threw him on the stretcher. We started to cut off his clothes, and we're doing all the things we do when we think we have a cardiac arrest, and there's all this excitement. And we're in this little rural hospital. We have 8 beds. We don't see that kind of stuff that often. And he sits bolt upright in bed and says, stop, don't cut my Carhartts. And he woke up and was fine. And we were like trying to wake him up the whole time, and he was just totally unconscious, playing possum. Apparently, he had a family member. They were in some dispute over some inheritance. And he thought the only thing he could think of, and there was a rifle pointed right at him, and he said the only thing he could think of was to fake his death and grab his chest and collapse to the ground and pretend like he had a massive heart attack. And then when he did that, I guess the relative that was pointing the gun felt guilty, and he dropped the gun, picked him up, and brought him to the hospital. So I don't know if he's just trying to scare him and he wasn't really going to shoot him. And I said, oh my God, you got to be kidding me. And the guy was fine. And I said, why did you think of this? He goes, I don't know, I saw it on TV once, and it seemed like a good thing to do, and it got him out of a jam. And he was really we cut his Carhartts. I guess they're pretty expensive overalls. But that was so many years ago. But I just remember, like, it was just the craziest thing. But yeah, they're all.
That's a great commercial.
Yeah.
That's a great commercial for Carhartt.
Yeah, it would be.
They should pick that one up and make a commercial out of that.
Yeah. And then so we had to clear out the waiting room because we didn't know if the guy was still loaded or armed with, a loaded gun. So we had to call the sheriff out there and evacuate the waiting room. It was a big mess. So a lot of stories like that. That's what I love about the variety. You never know what to expect, and it is stressful. It's probably where I got most of my gray hair. But I do enjoy, I still practice every other weekend, even though I work full-time as the medical director at Abbott Point of Care Diagnostics. I do like to take part in patient care. I don't want to give that up. And I still enjoy being able to help people in their time of need. It's not fun to be in the ER, and we'll maybe touch on some of that. Waiting times are long, and it's a stressful part of the day, and nobody really wants to be there. But if you can help people in their time of need, it's a good feeling. Yeah, I feel blessed to be able to do that.
Yeah. Well, it's nice to know that there's talent that as you're waiting to get into the ER and whatever, a malady that you have, as you're waiting, it's good to know that there's competent people like yourself that are waiting for me to take care of me. That's all I care about.
Well, we're practicing medicine, and we're going to keep practicing till we get it right. That's the adage I had.
Yeah. I'm curious about titles. So you have this title, Board Certified Emergency Medicine Physician. What does that mean, a board certified?
So when you finish medical school, you have to go through different residency programs depending on your specialty. So to become board certified by the American Board of Emergency Medicine, you have to go through a 3 or 4 year training program after medical school to learn to be a physician in that field. So if you're a pediatrician, you go for 3 years. If you are a surgeon, you typically go 5 years. Cardiothoracic surgeons go 7 years or more. Plastic surgeons. So board certified emergency medicine means I was trained to handle all life-threatening emergencies, and from delivering babies to traumas to strokes, heart attacks, and so forth. So you have to be a kind of a jack of all trades. So we rotate through all the different departments of the hospital so that you can be skilled at being able to do anything you need to do at that time. Now, back in the days, in the 70s, before emergency medicine became a specialty, anybody could be a family practice physician or an internist, and they can moonlight in the ER. So it wasn't always a specialty. So there was not always a residency program to go to become board certified. It got recognized in the late 70s as a specialty of itself, just like internal medicine, pediatrics, and endocrinology, and so forth. So that's what that means is you have to pass a board exam, and it's a pretty stringent process. And then to keep up the license, you have to go through continuing medical education and so forth.
Yeah. And then you've also in your past, and I'm assuming presently, are you teaching in a university?
I was, and I enjoy that too. So it's another way of giving back. And, when you've been doing it as long as I have, it's actually great and very fulfilling to be able to teach skills and teach emergency medicine to young docs that are right out of medical school that want to go into emergency medicine as a specialty. So I did that at University of Kansas Medical Center for almost 10 years as a part-time faculty there before moving to New York City during the pandemic, which seemed like a good idea at the time.
Yeah. And then you were also a contributor, or you wrote a textbook, is that correct, on the psychology of aging?
I didn't write a textbook, but I'll take credit for that.
Okay. Maybe that was another guess.
I have published some articles pertaining to my specialty and some of the other things I've done in my career, but not the textbook article. That wasn't me.
Yeah. All right. And I made this statement that there's over 5 million concussions reported in the ER room. That's a lot. What's going on there?
It is. And actually we see, and that's half of what we know is happening. So most people hit their head and don't even go to the hospital. So we know it's underreported and underrecognized for one. But we do get at least 5 million visits to the emergency room for a head injury. Not all head injuries result in concussions. That's important to remember. And some head injuries can be more serious and involve other complications, not just a concussion, but structural injury to the brain, bleeding in the brain, bruising of the brain, and skull fractures and other things. So it's a kind of a continuum. So there's mild head injuries, moderate, and severe. So it depends on the mechanism of injury. But concussions overall are underreported, and there are a lot of misconceptions among the public about what a concussion is, because everyone thinks it's just athletes that suffer concussions. And in fact, probably 95% of the ones we see are not in athletes. They're regular people tripping on the rug in the living room or losing their balance on the sidewalk or tripping on the sidewalk and hitting their head. It's not necessarily athletes. It's actually a smaller percentage of what we see in the emergency room that are attributed to sports.
Yeah. So let's start with, what is a concussion? What's the definition for whether it's in the medical side or on the street side, for just people in general? What is a concussion?
The simplest explanation or definition would be a blow to the head that causes disruption of the brain's ability to function properly. So that blow could be in the way of acceleration and deceleration, like when you're in a car accident and you stop abruptly, the brain can kind of move in forward and back within the skull itself. It could be a blast injury, as we see in the military, or it can be a direct blow to the head. And you can also get penetrating injuries to the brain, but that's less common. When we're talking about concussions, we're usually talking about blunt trauma. But that impact can cause stretching and tearing of some of the fibers and axons and all the things that make the brain function, all the neurotransmitters and chemicals that make our brain work the way it does for our memory and our behavior and our emotions. Those things don't work properly when those structural injuries to the brain occur. And sometimes those symptoms can be very vague and delayed and may not always be evident on imaging when we see people in the hospital.
So describe what's underneath our skin in the brain, to us, because as I understand it, there's a fluid that encircles the brain that keeps it kind of floating and protected from blows and traumas like you were just describing.
Yeah, there is. Your brain is basically floating in cerebral spinal fluid, which also goes all the way around your spinal cord and into your back. But more importantly, there's a lining around the brain called the meninges. And so when you have a blow to the head, you can get sometimes shearing of blood vessels that can cause bleeding. So you get bleeding around the brain. You can get bleeding underneath that membrane. You can get bleeding within the brain itself. But these blows can cause injuries, structural injuries to the brain itself. And that can be sometimes very serious or life-threatening. Now, in most cases, when we're talking about concussions, you do have some ability to absorb that blow, and some people do fine and don't have any symptoms or any complications. But there are a lot of people that can have ongoing problems from that blow to the head, and depending on what part of the brain is affected, because different parts of the brain control different things. The symptoms you have will vary based on what part of your head was impacted.
So that fluid is really important to protecting the brain. If that's true, then how does aging affect? So in other words, when I'm young, maybe in my 20s or 30s, is there a certain amount of ounces of this fluid that are floating around, to protect the brain? And then as we age, does that fluid diminish over time? Or if I had a concussion, is it like popping a hole like in a balloon and then I've got leakage and then I lose some of that fluid? How does all that work? I'm curious about that.
That's a great question. I haven't had that many people ask me that. It's not so much the fluid that changes, it's actually the brain density itself. So you can imagine your skull is fixed, right? Once you're an adult and your growth plates have fused, your skull's not going to grow any bigger as you get older as an adult. But the brain will shrink. So as we get older, there's invariably some degree of atrophy that will occur, especially in really older patients that are above the age of 75. When the brain will shrink a little bit, you have a little more space. It's not quite as tight. So you have a 20-year-old brain or a 10-year-old brain, it's pretty tight. So if there's any bleeding in the brain, it can be quite serious because it doesn't tolerate that extra pressure. But when you have somebody with atrophy of the brain, and elderly people, for instance, they can have a fall. And not only can they have a concussion, which is important for us to discuss today, but they can also have bleeding around the brain or a blood clot. We call it a subdural hematoma, where it can happen underneath that lining that we talked about earlier. And that blood clot may go unnoticed. They may not have symptoms because they can tolerate, a couple tablespoons of blood and not have a headache and not have symptoms because of that atrophy that occurs. There's a little bit more space in there for it to tolerate that blood. And sometimes people come to the ER a month later and they'll say, Grandma Mary is not acting right. She's a little bit confused, not quite as sharp. And you do a CAT scan and you find they've got a blood clot around their brain. So that's what happens as we get older is the ability to pick these things up and have symptoms is lessened. And so sometimes it can be very vague, symptoms can be very mild, people present in a delayed fashion. And more importantly, as we get older, the aging population are more commonly on blood thinners. So that's, going to make things even worse because the risk of bleeding around the brain or within the brain is going to be even higher as we age, and especially if you're on these blood thinners.
Mm-hmm. Well, let's talk a little bit about the signs and symptoms. So let's say I'm walking in the house and I trip on the carpet or I slip on the floor with my socks and I take a thud. Okay, so how serious then, and this is really common with seniors especially, so how serious do I take that fall? And then as I'm observing what's going on, what are some of the signs and symptoms that I should be looking for to know whether I should take mom, dad, myself to the ER?
Well, there's signs or symptoms that are more serious that require urgent evaluation for sure. And that's the things I alluded to with bleeding around the brain and so forth. So the things we look for in the emergency room are some red flags which prompt us to do a CAT scan. So it's loss of consciousness, altered mental status, seizures, persistent vomiting, and those kinds of things. Usually you'll have some amnesia, but someone's not acting right immediately after a head injury. You have to assume there's some major injury there until proven otherwise. Now, most concussions, I would say 90% of them don't have those structural problems. You can hit your head and not have those signs and symptoms. And it doesn't mean there's no brain injury. That doesn't mean there's no concussion. It just may not be something serious like I would describe with the bleeding around the brain. And so concussion symptoms are a little bit more subtle. It can be headache. It can be trouble with balance, dizziness, nausea, a little bit of confusion. Some people will have some amnesia. Some people will have a brief loss of consciousness, but the majority of people with a mild brain injury or a concussion will not have a loss of consciousness. So they'll usually stay awake. And sometimes people have trouble remembering details. They'll have some retrograde amnesia. If you're having trouble concentrating, and these things can happen within hours or it can happen within days or weeks. So it varies. And that's why it's important if you don't feel right, something's not right, and you probably should go to the hospital and get checked out. Now, we won't always do a CAT scan on every single person that comes into the ER, and that's the common misconception, because the people that come in think, well, I must have had a concussion. I want a CAT scan to tell me whether I had a concussion or not. And that's not how it works. The CAT scans we do aren't there to diagnose a concussion. We do a CAT scan to detect those things I described, which are more life-threatening, which happens less than 10% of the time. It's bleeding around the brain, bruising of the brain, skull fractures. That's what the CAT scan can pick up. 90% of people that actually have a concussion will have a normal CAT scan. So we do overutilize CAT scans sometimes, and the people think, well, my CAT scan's okay, that means I'm fine, right? I didn't have a concussion. That's far from the truth. This head injury may lead to chronic symptoms, and those symptoms of dizziness, headache, insomnia, those can linger for months or years sometimes. So it's important to get help, be evaluated, let the doctors decide whether you need imaging or not, and then try to make sure you get the referral to a specialist. They have neurologists and concussion specialists, and in some places that are skilled at dealing with this and detecting whether you've had a concussion or not, and detecting how severe it is, so they can help you determine how to go back to your normal routine.
So the principle "no blood, no foul" doesn't apply in this case with concussions. In other words, I used to say naively, well, if there wasn't any blood when mom, dad fell, then they're gonna be okay. And yet that's not always true. Because blood usually comes from, abrasion from the skin, but that doesn't have any indicator towards what's going on inside the brain.
That's absolutely right. When you twist your ankle, it swells up right away. You can see it right in front of you that you have a swollen ankle. Something's not right. I either sprained it or I might have broken it. But with your brain, you don't know what's going on underneath the skull. You don't have to have a big goose egg. You don't have to have an abrasion. And you certainly shouldn't have any fluid leaking out of your nose or out of your ear. If you do have that, that's pretty serious, and you might have a basilar skull fracture. But we typically don't see any outward signs of head injury with most mild concussions that we see. Now, if there's a big goose egg, I'm going to be more concerned, and I might do a CAT scan, depending on the mechanism, if they lost consciousness and have those other signs and symptoms I talked about. But the problem is why it's difficult to diagnose the brain, and that's why it's really exciting with some of the technology, which maybe we can touch on, that's come out now that wasn't around 25 years ago when I was in training. We're able to see what's going on with the brain with blood tests now, which before we didn't have that. We just did our exam, and we kind of made a judgment call whether we needed to do imaging or not, but it was really hard to know what's going on under the brain. Like when you have chest pain, we can draw blood tests and measure a protein in the bloodstream called troponin that's elevated, tells us whether there's damage to the heart. And when we have liver injury or kidney injury, almost all the organs in the body have some blood test that we can use to diagnose and assess, but we didn't up until now have anything like that to assess the brain in combination with CAT scans and a good neurologic exam.
Yeah. So if a senior falls on the floor and you attend to them right away and you start observing what's going on, and you're going, everything seems to be fine. But that's not necessarily true. And so there could be some delayed symptoms is what you're saying. How often should I, as the adult child in the situation that came and checked on mom and she says, I fell earlier today. I think it's important to check back if you're an adult child, even though you're not living with mom. How often should we check back to say, hey, you okay? Or how should I do it over the phone? Should I come over and make some observation? I mean, these are really practical things that I think we should be paying attention to.
Yeah, and that's tough. It depends on how bad the injury is, of course. In the hospital, we're always doing neurology checks on patients every couple of hours, right? Because things can change over time. That's not practical if you're not living in the same household or in the same city for that matter. That's why I think it's important to try to get somebody there. That's the most important advice I can give is if there's been a head injury, they should be observed kind of continuously. Somebody should be there with them and not let them be alone, because they could start getting worse. And you really won't know. And it's hard to say, every couple hours, every 4 hours. That's why it's important to err on the side of caution and seek, evaluation when you're not really sure, especially if it's an unwitnessed fall. A lot of elderly will fall and it wasn't really witnessed, and you ask them if they were knocked out or not. They can't tell you because they won't remember if they were knocked out or not. And so that's where it gets a little riskier, is when nobody was really there to see the fall. That happened with my father, who recently passed away at the ripe young age of 100 years and 1 month. He had an unwitnessed fall, and my mom didn't think anything of it. He seemed to be acting okay, and he came to the hospital later for other reasons. And then when they scanned his head, as they were doing their thorough workup, they found a blood clot around his brain from a fall that happened presumably a week or two earlier. And he just never sought medical attention because I'm fine. I've got a little headache and I'm okay. So a lot of people minimize it. But it's important to have family members or friends, be there to observe the person if there's been a head injury, especially within the first 24 hours.
Yeah. I think the key word that you said was he thought he had a little headache. If you have any headache at all after a fall, how serious should I take this in getting myself down to the ER?
You should take it very seriously. And that's where it gets, the water gets muddied a little bit when they show up in the emergency room and they have a history of chronic migraines, or maybe they were drinking the night before and the next morning they may think their headache is due to a hangover. Oh, I just drank some cheap wine. I'll be fine. I'm just a little nauseated and I've got a headache from that. And then you don't really know. So I think, but any headache is cause for concern. And those headaches can be persistent for some people that have concussions. Some people will get better on their own, but it's important to get advice and seek medical attention, because it could be a sign of something more serious, especially, again, the aging population on blood thinners. That's a big red flag. Headache, fall, head injury, that's a bleed until proven otherwise. Now, we're always concerned about concussion, but we're more concerned about missing that serious complication.
Did you know that 5 million Americans go to the ER for a concussion every year? But more than half of the people who suspect they have a concussion never get it checked. This is a serious problem, as concussions can lead to memory problems, headaches, depression, and more if left untreated. For your best shot at a full recovery, get professional medical help immediately. This Did You Know moment was provided by today's guest and is brought to you by Royal Hospice of Oregon.
Yeah, and concussions, anyway, and I think this is pretty obvious, but concussions really are not age-related. So I'm going to share a story with you to prove that point, and I'm sure that many out there have had similar stories. And that is my son, who is a longboarder, skateboarder, and it was really common to longboard to classes going to the university. His brother-in-law was longboarding, fell off his longboard, went home and went to sleep, and nobody knew where he was. He'd just walked into his apartment, and the next morning they found him, delirious and half conscious, and so they took him to ER and found that he literally had I don't know if it was a concussion, but there was bleeding around it. I don't know if that's part of some of what's going on with a concussion, is bleeding around the brain, and he ended up losing his life over it at the age of 22. And that's just too young. So falls you got to take serious. Doesn't matter your age.
That's exactly right. And I'm so sorry for that. That's horrible. But it can happen at any age. It can happen to a young brain. It can happen to an older brain. We have to protect our brain. We only have one. And so you never want to take a chance. You just never know. It could be something mild. And I wouldn't say concussions are mild. When we get the bleeding around the brain, we call that medically a moderate to severe traumatic brain injury, or TBI. The concussions are by definition the mild ones. So they're typically awake, alert, oriented, no major concerning symptoms. But I wouldn't say it's mild, because when they've done some studies on patients in follow-up, they found 17% of patients with mild concussions were unemployed a year after their head injury. Well, if you lose your job because you can't sleep and you have persistent headaches and depression and insomnia and difficulty concentrating, I would say that that's probably not mild at all. So the nomenclature is actually changing in the near future. The medical community is getting together. All these experts in neurology and psychology are gathering to change the redefinition of head injury. So it's no longer mild, moderate, severe. We're gonna be using a different framework to classify these head injuries. That's why it really does need to be something that people are cognizant of and that they get follow-up for, so they can get help and again, rule out that really bad bleed that might take the life of someone if it goes unnoticed. But more importantly, if you don't have the bleed, which, as I mentioned, 90% of the people we see in the ER, if we did a CAT scan on them, the CAT scan is going to be normal. Now, they may have still had a concussion. We have to do MRI scans and other neurocognitive testing. And those things, again, need to be taken seriously, because there are things we can do now. There are therapies that may help them get over their symptoms and minimize the risk of persistent post-concussion symptoms.
Yeah. I think the moral of the story is, if you do fall, it doesn't matter what age you are, whether you're 22 or 122, tell somebody that you've fallen. And because you just don't know, and if you don't share that story with somebody else that can help observe and watch you. But there's something interesting about the psychology of us as human beings is, it was nothing. I've fallen all my life, but yet I think as a senior, especially, make sure that you share that information with somebody so that there can be somebody to look after you in case something does happen.
That's absolutely right. And now we have a lot, again, we have a lot more we can do. We've learned a lot over the last few decades about concussions and about assessing people. I think a lot of people, as we talked about before, half of the people won't even show up. So half the people don't even get assessed. So we may find there are more and more concussions out there that we never see in the emergency room or never get diagnosed. I know it happens a lot with athletes because they minimize their symptoms and they don't want to get pulled out of the game and be sidelined. But even again, in the aging population, they just want to minimize things. Oh, I'll be fine. I've got a headache. I'm tired. I'm dizzy. I'm just getting old. That's how my dad was. He just kind of brushed it off and didn't think anything of it, didn't associate the two together. But we have more technology now. We have a blood test that, Abbott has this iStat TBI cartridge, which we can actually detect with 2 drops of blood. When people come in, we can determine whether or not they had an injury severe enough to cause bleeding or require a CAT scan. Because part of the reason I think people don't want to go to the hospital, they don't want to wait. They don't want to be in the waiting room. Yeah. They don't want to, and some people are worried about the cost. They don't have health insurance and they're worried about the radiation of the CAT scan. So what's nice now is that we have a way that we can quickly assess people more objectively with this blood test that measures these 2 brain-specific biomarkers. And in the absence of elevation of either of those biomarkers now, I as a physician can tell this person, reassure them, you're fine, you had a head injury, it's mild, you don't need a CAT scan. The likelihood of you having a significant concussion is pretty minimal, and you can go to sleep and not worry about not waking up in the morning. And that's what people worry about. They come in and say, well, do I need to wake the person up every 2 hours? Do I need to stay with them? Well, having this blood test now will allow us to be able to objectively tell people how much at risk they are and send them home quickly, which is really exciting.
I find that fascinating. How from 2 drops of blood, you said, can you learn something that there's some kind of trauma? What are there little cells in there that are saying, help me? Is that what do you see through the microscope that says, hey, there's been a trauma here in a blood sample? I find that fascinating.
It is pretty fascinating, and scientists have been working on this for a couple of decades through work with the DoD. Abbott helped to get this to market, and actually it's a FDA-approved test. It's available now. Not every hospital has it because it is so new, but they're brain-specific proteins that are released into the bloodstream. So those proteins should not be in the bloodstream when there's a brain injury, just like with the heart. When you have a troponin in the blood, that measurement means that there's damage to the heart muscle. It shouldn't be there. It's pretty specific. So these markers are specific to the brain. So when there's an injury, as I mentioned before, you get stretching and tearing, structural injury that causes this to leak into the bloodstream. And if we can detect it with just a couple drops of blood, which is pretty fascinating, they can measure the quantitative level that those markers are, because what research is now starting to show, and where I think the future is promising, is based on how high those markers are, we might be able to do some risk stratification and prognostication to determine how bad their concussion is and their likelihood of recovery. But what it's cleared for now by the FDA is kind of a rule out test. So if neither of these markers are above the established cutoff, then we can pretty much rule out the need for a CAT scan. So that helps us as physicians to assess people quickly and objectively, and not immediately send them down the hall to get a CAT scan, which may take 3 or 4 hours to get the results from, and which they may not have needed, because 90% of the time it's going to be normal anyway. So it really is changing how we assess people, and we're hoping in the future this may be available now with a whole blood test, a couple drops of blood in certain urgent cares and ambulances, maybe someday even on the playing field, to be able to assess people right there at the point of injury, rather than having to transport them by ambulance to the hospital.
Well, what are the barriers from keeping that out of all the hospitals and all throughout the medical system? I mean, that seems like a no-brainer. No pun intended.
No pun intended. It is relatively new. So there are societies now that have started to adopt biomarkers as part of the assessment. The American College of Surgeons establishes brain injury guidelines, and that just last month, actually, they published their guidelines. So as these societies and as these guidelines start to mention this, more and more clinicians will become aware of it, and hospitals will put these devices in practice. So the other barrier from like outpatient settings is regulatory bodies. So there are certain types of complexity to testing. So when you do diagnostic testing, there's moderate complexity testing and high complexity testing. So some sites have to have a license or registration by the lab regulatory bodies to be able to do that testing. It's not like going to the drugstore and getting your Binex Now test and doing your own self-COVID test. That's a different level of complexity. Yeah. So these tests can only be used in places that have that moderate complexity ability, and many urgent cares do, or places that have a stat lab. You can't just put it up everywhere, but that's where we hope the future will be. I think that's where we'll start seeing this more in remote areas where they don't always have a CAT scan available, urgent cares, walk-in clinics, again, ambulances, to make decisions in the field whether somebody really needs to go to the hospital or not. But that's the only thing that's keeping it, is how new it is, and the lack of awareness by many physicians about these biomarkers and about the Abbott iStat TBI test that's available.
Is it so you get this little couple of samples of blood? Is it a machine then that separates and analyzes is it an expensive process to get? And how big is this machine? Is it a desktop? Is it fill up a room? Describe what that is. And then I'm excited about, the same thing that, we did with COVID, where you swab the mouth or the nasal passage, to be able to take that blood test, and boom, you can tell right there. And how close are they to that level of technology?
So that's, I'll answer the first part. So the machine varies. So Abbott has these two biomarkers cleared on their big, huge lab machines in the core lab. So when you go to the hospital and you get blood drawn and we send it to the lab to do chemistries and other types of tests, it's on their big machine. It's called Alinity I or Architect. That's the big lab machine that you'll see that does a lot of blood counts and chemistries and electrolytes and so forth. So it's able to be done on that machine, but it's also available on what's called, I referred to it earlier, it's called iStat. And I practiced in Kansas City at a hospital where we used this a lot. It's a handheld analyzer that has cartridges where you put a couple of drops of blood and it gives you results anywhere from 2 to 15 minutes. So for blood gases and other types of tests, it could take a couple of minutes. For this brain injury test, it takes 15 minutes. But you put the drops of blood in the cartridge, you insert the cartridge in this handheld analyzer. It's probably I don't know how to compare it. It's not that big. It's bigger than a TV remote, but you can hold it with one hand. Has a touch screen, a color screen, and the machine actually has microfluidics that occur. It's pretty fascinating, the technology, but the cartridge has a way that the blood will actually go back and forth across sensors, and it's really fancy technology called ELISA, which is an immunoassay. I won't get into the details of it on this call, but it's a way of looking for these things with these sensors, and just from those 2 drops of blood, the cartridge can do that via the microfluidics that the analyzer is capable of to get it to pass that sample to pass back and forth across the sensors. So I can't share the details of the secrets, but it's not magic. It's definitely technology that's pretty amazing, and the engineers are pretty phenomenal that have come across this, not only to be able to do it on a big machine, but also do it on a handheld machine. But we use that same similar handheld machine called iStat for other tests. As I mentioned, a lot of emergency rooms across the country are already using that for things where they want the answer within a few minutes, and the patient's really critically ill, and that we can't wait for the lab to send us the results, which may take 30 to 60 minutes sometimes.
What's the accuracy rate of it? I mean, is there anything that would cause, a false positive or a false, negative or, with the blood?
That's a great question.
I don't even know if that's right. No, it is a great question.
That's exactly right. Yeah.
Because, and the reason why I bring that up is because, that was the big thing with COVID, right? False positives and negatives. And it was like, oh my goodness, they don't know for sure. How accurate is this machine in knowing for sure? Is it a done deal, or is there some variables?
Yeah, that's a great question. For most diagnostic tests we do in medicine, we want a high degree of sensitivity as well as a high degree of negative predictive value. So you don't want any false positives if you can avoid it. But more importantly, you don't want false negatives. You don't want to miss something. So this test has upwards of 96.5% sensitivity, maybe even higher according to some studies of places that have been using it. And the negative predictive value is quite high as well, upwards of 99%, depending on the prevalence of head injury. But 96.5% is the number that was quoted in one of the big pivotal studies they did that led to the FDA clearance, which means, yes, it's not 100%. There will be false negatives from time to time, but none of those require any neurosurgical intervention. So the ones in the big studies that were done of where we used the blood test to determine we didn't need a CAT scan, of the ones that were missed, and it was a very small handful compared to the thousands of patients studied, none of those people had bleeding in the brain that was serious, nothing that required neurosurgical intervention. So they had good outcomes. There is really hardly any test we use in emergency medicine, especially, that's 100% accurate. So it's quite sensitive, adequate compared to what we're doing now, which is really subjective, and this is more objective.
Yeah.
But that's a great question.
Yeah.
And it had the sensitivity, specificity, and negative predictive value that was sufficient for the FDA to clear this for use in hospitals in the US and the United Kingdom, Hong Kong, New Zealand, and other parts of the world. So slowly this technology will start to get registered and available all over the world, not just in our country.
Yeah. So does this have a name, this particular? So if I'm going to the hospital, I have a concussion, I can ask the hospital, hey, do you have the Abbott blood test machine, or how would I, bring awareness to that?
That's a great question. Again, not every hospital has Abbott in the core lab, but you can ask for the TBI test. So if they have an
TBI?
Abbott machine,
Okay.
TBI stands for traumatic brain injury. So if they happen to have an Abbott machine in the core lab and they're using that technology there, they can do the test in the core lab. If they're using the handheld analyzer, it's called the Abbott iStat TBI cartridge, which is used on the Abbott iStat analyzer or iStat system. That's the handheld system, which I mentioned earlier, can take iStat takes several cartridges for different various blood tests that we do in emergent settings. So you can ask for that. Do you have iStat here? Do you have the TBI test is the simplest way. But again, it's new, and not every hospital that is using iStat has the next generation iStat analyzer yet that can do this TBI test. So it's so new that I think you're going to, it's not rampant yet, but I think it will get adopted very quickly over the next 12 months or so as more and more research.
Are there certain parts of the country where hospitals do have them? Are we talking Midwest, Northeast, East Coast, West Coast? I mean, where is it predominantly being used?
There's at least 30 hospitals that I'm aware of right now that are using the iStat analyzer, the handheld test. Florida is where it started. So the first place to use the plasma test was in Tampa. The whole blood test, which is where you actually draw the blood from the vein and put the drops directly into the cartridge. You don't have to centrifuge the sample like before. That whole blood test was cleared in April of this year. It was made commercially available in July. And Orlando Health, Dr. Linda Papa is a researcher who's been researching these biomarkers for years. They were the first hospital in the world to actually start using this. And there are many other hospitals in Florida following suit, and which is actually great because a lot of our aging population tends to retire in Florida. So you have skilled nursing facilities and assisted living, and a lot of retirees that tend to trip and fall, lose their balance. They have weakness, they have balance issues. So it actually is quite fitting that they are the first part of the country to start using it. But there are other states that are following suit as well. I know the hospital in Colorado is using it. I have to mention UCSF in San Francisco, Dr. Jeff Manley, and many of the researchers with what's called Track TBI. They're a network of researchers that have been researching these biomarkers for over 10 years. Jeff Manley is leading the way at UCSF, and they're using the test there, I believe, in the near future as well. They've already been using it in research settings. Michigan is another one. University of Michigan and Dr. Fred Corley and their institution, they've been using this test as well. So it's really on the cusp of something that's going to change standard of care. It's not standard of care yet because it is so novel, but with more education and awareness and more of the guidelines adopting this, encouraging physicians to use this objective test, I think we're going to see it more and more often.
So if I've been diagnosed with a concussion, what's my treatment? I mean, are you going to send me home with where I with a neck brace so I can't move my head? And, I mean, what transpires after that, after the diagnosis?
That's a great question. Basically, the overall theme is just to take it slow. So when people go home after a mild concussion, we tell them to just have their recovery be paced based on their symptoms. So it depends on what their symptoms are, but you want to never go back right to work and go right back to your normal routine. Back in the old days, we used to tell people, go sleep in a dark room and don't watch TV, don't get on the computer, don't read a book, just stay in bed. And they actually found that it made people worse. Their recovery was more prolonged. So they promote an active, gentle, slow recovery. So we want people to stay active. You need to exercise, gentle walking. You get on the treadmill if you'd like. I wouldn't be doing any major HIIT classes at the gym or taekwondo or anything crazy.
No boxing.
No boxing where you're going to get a repeated blow to the head. And obviously, whatever you're doing, if it's making your symptoms worse, let's say you're at the computer and you have a headache that's starting to get worse again, then stop, take a break, take frequent breaks and limit how much time you're on the computer, on the TV. With the younger people, we tell them watch their, how much time they're spending on the video games, on their phone, on social media. Any of that overstimulation of the brain will cause these symptoms to come out. So it's basically take it slow, reintroduce your normal activity in a graduated fashion, but your healthcare provider can help guide you how quick that can be. For some people, they're back to work in a week, and some people it takes 4 to 6 weeks to get back to being 100%. I had a concussion myself about 6 months ago. It took me about 6 to 8 weeks to be where I could feel like I was back to normal again. I had trouble concentrating. I had headaches and trouble sleeping. I just wasn't feeling right. And so it just takes time. Everybody is different. We find actually females are more prone to concussions more than males because of structurally and hormonally, there's something with the brain that's a little bit different. So we're finding more and more with research that females are more vulnerable to concussions. We're finding this true in the athletes as well. But everybody is different. Not everybody will recover as quickly as the next person, but it's important to just take it slow. And there are therapies. So depending on the symptoms, if you have depression, they might send you to a neuropsychiatrist. They might put you on an antidepressant. If you have trouble sleeping, there are supplements that may help with that. If you have trouble with dizziness and balance, they might send you to ear, nose, and throat or to vestibular therapy. So you might be able to go to physical therapy and work on strength and balance exercises. So there's different ways of treating the symptoms based on what the symptoms are. So there's not really a magic pill. It depends on what symptomatology you're having, and that will dictate what your therapy or treatment will be.
Yeah. So a concussion will gradually get better. Is there any scarring that happens where after you feel better and the symptoms are all gone, you don't have headaches anymore and blah, 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 all the things that go along there? Is there scarring? And then is that, if there is scarring in the brain, are you more susceptible to getting a concussion, repeated concussions over and over again?
You are. And if it's a mild head injury and a concussion without any structural abnormality on CT or MRI, there's not really any scarring per se. Like when you scrape your arm or you cut yourself, you'll see a scar there, a visible scar. Theoretically, you won't have that type of scarring per se, but you are at risk for repetitive concussions, and it's cumulative. So these proteins that are released in the bloodstream, there are some biomarkers, not the two that are in this Abbott test, the GFAP and UCHL1, but there are other biomarkers that actually remain quite elevated chronically, and that's what they're tracking for people that have chronic traumatic encephalopathy, because there is a cumulative effect, and your risk of a further concussion is heightened when you've had a concussion, because you might have trouble with dizziness and balance and concentration and coordination, and that can lead to another head injury. So when you have these repeated blows, that can definitely prolong your symptoms, and it can be permanent. So people that we're seeing this with athletes, this thing called CTE, which is very controversial, but it's really a thing. Chronic traumatic encephalopathy is where the brain over repetitive blows over time, and we do see this mostly in athletes, can cause permanent injury and neurodegenerative changes that can mimic Parkinson's and Alzheimer's and other types of neurodegenerative disorders.
That's where I was going to go with this is, what are some of the long-term effects, and is there any correlation between concussions and dementias of various kinds?
There is. And again, it's quantity and severity, and it's cumulative. So one fall and one blow and one mild concussion, assuming you follow the right recommendations for recovery, shouldn't lead to chronic problems. Majority of people will get better on their own and have no sequelae, long-term sequelae. But the people that have repetitive injuries can be at risk for chronic neurologic problems.
Yeah. And then does it take on a whole nother level of, therapies to recover from, from a concussion that translates or, goes into a dementia of some kind? Then there's a whole nother level of treatment.
Yeah, and they're studying that now. They're studying different pharmacologic agents to treat those types of injuries, as well as preventative. So there are things that they're studying now, and they're using some of these brain biomarkers early on to help select the people that can benefit from these therapies, but more preventative medicines. So when there's been a concussion, there are drugs on the horizon that might minimize your risk of a concussion or complication from a concussion or chronic sequelae. So those are not, quite ready for prime time yet. There's a lot of research still underway, and for some of those to get to market and to be used in the mainstream, I think is going to be another couple of years or so. But there are therapies there.
Yeah. And Dr. DeValantis, we're up against the end of our show here today, and I just want to say thank you for being on Aging Today. But if someone wants to get in touch with you and they want to learn more about concussions, what's the best way to get in touch with you? And then secondly, if somebody that is interested in learning more about the Abbott blood test, how would they get in touch with you or somebody at Abbott?
A couple different things. You can go to Abbott's website, and it's abbott.com/brain-health. So abbott.com/brain-health. And you can also go for symptoms, some information about symptoms of concussion and other information. We have an alliance or partnership with Concussion Awareness Now. So you can go to concussionawarenessnow.org. That's all one word. Concussionawarenessnow.org is another website that's very useful that talks about symptoms of concussion and what to watch for.
Yeah, that would be very helpful and great information to have at your fingertips. So anything else that you want to, impart on to our listening audience about concussions that we haven't talked about?
I think we covered it all. I really appreciate the time. I think the best advice is, don't delay. A lot of people minimize this entity, and when there's frequent falls like we see, especially in the winter months, now we're going to have a lot of slippery pavements and people out shoveling the snow and slipping and hitting their head. Don't delay. If you're not sure, like you said, it could be a loved one, it could be an older relative. When in doubt, send them out is my adage. If you're not sure, just go to the hospital and let us evaluate your loved one or yourself to make sure that you don't have anything more serious going on. That's the best advice I can give you if you're not sure what to do.
All right. Dr. Chris DeValantis, thank you so much for being on Aging Today. We really appreciate your time, your expertise, and the wisdom that you brought to our conversation about concussions.
Thank you for having me, and I hope I don't have to see you at work one day. At least not at my other job in the ER.
And I'll have two options. He'll either ask for a CAT scan or a TBI.
That's right. Or
Did I get that down?
Yeah.
Yeah, the blood test. Yeah. Okay. All right. Sounds good. All right. This is Mark Turnbull, your host, and I want to thank all of you for tuning into Aging Today. We are the podcast where together we're exploring the many options to aging on your terms. And then join us every Monday when we release a new conversation on Aging Day to your favorite podcast channel. And remember this, we're all in the process of aging, and as we age, we really are better together. So stay young at heart.
You make me feel so young. You make me feel like spring has sprung. And every time I see your face, I'm such a happy individual. The moment that you speak, I want to go play hide and seek. I want to go and bounce the moon just like a toy balloon. Well, you and I are just like a couple of tots running across the meadow, picking up lots of forget-me-nots. So you made me feel so young. You made me feel there are songs to be sung, bells to be rung, and a wonderful thing to be fun. And even when I'm old and gray.
You've been listening to Aging Today, where together we explore the options to aging on your terms. Join Mark and his guest next week for another lively discussion on proactively aging on your terms, connecting you to the professional advice of his special guests, with the goal of creating better days throughout the aging process. Your host has been Mark Turnbull. Join Mark and his guests every week on Aging Today, your podcast to exploring your options for aging on your terms.
And even when I'm old and gray, you make me feel the way I feel today, 'cause you make me feel so. You make me feel so. You make me feel so young, so young. You make me feel so young. You make me feel so young.